AW is a 5-week-old male who was admitted to the pediatric intensive care unit last evening for respiratory distress. AW is a 5-week-old male who is previously healthy. He is born at 39 weeks gestation, and he is the third child to his married mother and father. Approximately 3 days ago, the mother stated that AW developed cough, rhinorrhea, lethargy, and decreased oral intake. He was brought to the urgent care earlier yesterday morning, who sent him home with prescriptions for albuterol and prednisone. Mother attempted the albuterol with no success and did not give any of the prednisone. She brought him to the pediatric emergency department last evening, where he was found to be having oxygen saturations of 85% on room air, has significant retractions, was very tachypnic, with a severe cough. A respiratory vital panel was obtained, a chest x-ray was done, and he was placed on 6 liters high flow nasal cannula at 35% oxygen. He continued to remain in the low 90s on his own oxygen saturation, so he was transferred to the pediatric intensive care unit. According to the mother, she states that AW has had low-grade fevers for the past 3 days, and that he has had this increased rhinorrhea along with difficulty breastfeeding, cough, and nasal congestion. He has continued to make wet diapers and stool. He has had no history of ear infection, no ear tugging, no eye drainage. She has attempted to give him Tylenol, which has seemed to calm him intermittently. She has not complained of any rash or redness. His immunizations are up to date, and he has no known allergies. She otherwise denies any vomiting or diarrhea, and has mostly been complaining of the upper airway congestion and difficulty breathing and eating. As stated before, his past medical history is significant for being a term male infant, the third child of his parents, and there are no sick contacts in the home. On physical exam, he is pale and breathing quickly with subcostal and intercostal retractions. He has a frequent dry cough, along with some rhinorrhea that can be suctioned. He does turn ashen gray or blue during these coughing episodes. Mucous membranes are moist and capillary refill is brisk at 2 seconds. Head is normal cephalic and atraumatic. Eyes are white and clear with extraocular movements intact, and pupils are 3 millimeters and reactive to light. His neck has full range of motion with no difficulty. Chest has equal symmetric expansion. He does have coarse lung sounds in the upper and lower airways, along with his barky cough. S1 and S2 heart sounds are heard, and he is tachycardic. Pulses are +2 in all extremities, and he is warm and well perfused. No murmur is detected. His abdomen is soft, non-tender, and non-distended with active bowel sounds, and he is acting hungry. He moves all extremities with equal strength, and there is no evidence of weakness or deformity. His skin is warm and dry with slight mottling during his crying episodes. There are no rashes, lesions, petechiae, or purpura noted. And neuro-wise, he is an alert and appropriate 5-week-old male. His differential diagnosis includes respiratory syncytial virus, another viral illness including adenovirus or norovirus. He could have aspiration pneumonia. My plan for AW is to keep him admitted in the PICU and consider intubation if his respiratory rate and oxygen saturation, if his respiratory rate continues to increase and his oxygen saturations and lung sounds continue to worsen. We will be ready with rapid sequence intubation medications if needed at the bedside. We will keep him comfortable and with Tylenol and to cover any fevers that may occur. We will place an NJ tube for post-pyloric feeding, and he will get his non-fortified mother's breast milk. He will continue on the cardiorespiratory monitor for monitoring of his tachypnea, respiratory rate, oxygen saturations, and blood pressure. And we will continue with every 3-hour nebulations albuterol and hypertonic saline nebulizations as needed.